Dr. Prashant, we can start.
Yeah, we are live now, madam. Hello, doctors. Good evening, and welcome to this experience sharing program on managing PPH case studies from labor room. We have got honorable speaker Dr. Buvaneshwari with us today. Welcome, madam. Good evening.
Good evening.
This program is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare has 25 years of excellence since 1993, 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely-held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360 degrees solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirus, offered oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Experience Sharing Program on Managing PPH. As I said, we have got honorable speaker, Dr. Buvaneshwari with us. Dr. Buvaneshwari Madam is MBBS DGO DNB in Obstetric Gynecology, Diploma in ALS from Germany, AMR COG from UK, FICOG Medical Director GBR Fertility Center, Chennai, Tamil Nadu. Madam is Medical Director GBR Fertility Center, Chennai, fertility specialist and laparoscopic surgeon, certified robotic surgeon, member ISAR, ESHRE, ASRM, IAGE, IFS, FOXY, AMR COG, IMA, OGSSI. Prestigious IMA HQ Professor Award in 2024, what Madam received. Teaching faculty for ICOG and postdoctoral fellowship programs. Madam has received MQR Young Talent Award in ISR 2022. Dronacharya Award by Tapisar in 2023. Vatikutty Scholar and Best Video Presentation Awards. Made GBR ranked in top 5 centuries in Tamil Nadu for top 5 centers in Tamil Nadu in last 8 years since 2016. Excellence in Reproductive Medicine Award by Times Health in 2020. Inspiring Gynecologist Fertility Conclave Chennai 2019. World's Greatest Leader Asia 1 and URS Media Dubai 2018. Stalwarts Award Healthcare Achievers Award 2018. Women Startuppreneur Award 2016 from CII. Recipient of Best Doctors Award from Lions Club Chennai 2014. And with this brief introduction, I hand over the session to Dr. Buvaneshwari. Over to you, madam.
Thank you, Dr. Prashant, for a wonderful explanation and introduction. And today is going to be one of the complication what we see when it is unexpected, and it is the most dreaded complication in obstetrics. And as we all know, every woman goes through a pregnancy, whether it is high risk or not a high risk. At the time of delivery, we must be prepared for 3 complications. One is that PPH, another one is trauma, and third is the sepsis. So, among all three, again, postpartum hemorrhage is one of the most common complications of the childbirth. And globally, we know that it's almost 1/5 of all the maternal death, even now. In most low-income countries, it is still unpreventable, and if not managed properly. So it is a main cause of maternal mortality still. It is an unfortunate thing. Second slide. So what is the updated WHO for definition? This is a FICO 2025 has released a guideline where it is said that to identify women at risk of adverse outcomes from postpartum bleeding and initiate the first response treatment, it is recommended to use the following criteria. There are 2 criteria. One is that objectively measured blood loss threshold of more than 300 ml with any abnormal hemodynamic signs. That is, pulse could be more than 100, a shock index more than 1, a systolic BP of less than 100, and diastolic blood pressure of less than 60. So, if you see any of these vitals abnormality or blood loss of more than 300 ml, you have to get ready for a PPH drill. That is what they say. Or we can always take the old classification of objectively measured blood loss of more than 500 ml, whichever occurs within the first 24 hours after the birth, and particularly during first 2 hours is considered as PPH. And why this definition is changing and the classification they are making changes with the vital signs to give the people or doctors aware of these things to get prepared for the worst complication, and also get some time for a shifting when you are in the low resource setting. You have to identify early and so that you can be prepared and you can always have a time to shift the patient. So once you are reaching 500 ml or 1000 ml in cesarean, again we are losing the first golden hour. So that is why the classification is getting changed. So next, so what are the etiology? So we know all four T's are there here. First one is uterine atony. That is the maximum number of cases we see. That is only unpredictable, and sometimes it is not within our control. So inability of the uterus to contract, which may lead to continuous bleeding. And thrombin, again coagulopathy, failure in clotting. This we might have some precaution. Sometimes we might know earlier. We will be able to diagnose and be preferred for it. Trauma, again, of course, when you do a big baby, when you do a instrumental delivery, when you do when you expect a precipitate labor and shoulder dystocia, so many reasons you know you can expect, and then at least look for the uterine trauma and be prepared for it. Next is a retention of a placenta, and this is again one of the recently we are seeing more and more because of women going through a lot of myomectomies, hysteroscopic procedures, previous DNCs, and multiple surgeries like no septal resections, whether it is there or not. Like no, lot more things. Trauma is happening within the lining of the uterine endometrium. Again, because of the IVF cases, we are seeing more and more placenta previous, retention of placenta, even in second trimester miscarriages and preterms are there. So this is again we are able to nowadays predict and say. So among all four, you can see this uterine atony alone, we don't know. Even primary can go for atony. Sometimes multigravida can have a normal contraction. So unpredictable is a uterine atony, which can be prevented prophylactically. Next slide. So how do we diagnose this PPH? We know as per the cause, we have discussed already the causes. Depending on the cause, we can expect some abdominal tenderness in case of rupture or inversion, or increased blood clotting inside, circulatory collapse, increased abdominal girth, loss of uterine contractions. You won't be able to palpate the uterus, maternal tachycardia, and vaginal bleeding. These are all the clinical findings which immediately you can pick up. Again, according to the classification, degrees of shock also we have to identify based on blood loss, blood pressure, and symptoms and signs. So when they have 500 to 1000 ml, almost a 10 to 15% of blood loss is expected, because in a pregnancy the volume is increasing. It is getting prepared and getting compensated, and blood pressure may not change, and at that time we don't need to worry about that. When it crosses 1000 ml, or 1500 ml or 2000 ml, depending on that it is mild, moderate, and severe. Again, we have to see the blood pressure changes. If it is a slight fall less than 80 to 100 systolic, then we can at least have some time. Suddenly if it falls below 70, 80, you have to really act, and the severe is almost patient is into shock. Again, symptoms, if you see, are depending on the circulatory changes, you see them having weakness, sweating, tachycardia. If it is very severe, they can go for a collapse, air anger, and hypoxic anuria and everything you can see. So again, diagnosing postpartum hemorrhage, there is a pattern. It can be simultaneous or one after another, but it should be very quick. Initial evaluation, it should be immediately rapid assessment of patient status. Whether patient is conscious, alert, responding to our calls, whether she is looking pale, all that assistant has to look for it. When you are delivering, doing something, patient has to be monitored. Presence of tachycardia and hypotension, you have to monitor. Assessment of vital signs and blood loss, again you have to assess. So that is why important of collecting the blood, having the tray, or there is a nowadays a drape set itself is coming with the plastic covers where we can immediately have some assessment. At the same time, you have to look for the traumatic bleeding, any assessment of genital tract lacerations, hematomas, and uterine rupture in a multigravida or big baby, or precipitate labor, or when they give fundal pressure and then refer the cases. Those are the cases you can expect uterine rupture. Manual examination of placenta, if at all it is eaten, you have to make sure that there is no bits of placenta inside, and always bring the scan, make sure that there is nothing inside the uterus or the uterine rupture we can pick up. And these are all the things immediately you have to pick up. And simultaneously, the blood has to be sent. Whatever reason could be there, when the blood loss is happening, patient is going into the circulatory changes, you ought to start collecting the blood for hemoglobin, hematocrit, and platelets, coagulation, electrolytes mainly, and again coagulation profiles like fibrinogen and all, with D-dimer. Those investigations as a protocol, it should be stuck in the labor room, and whenever there is an alert is coming, the set of blood tests has to be taken. We always keep a note of it, like how we say, like a surgical pack. If the patient is going for surgery, these are all the checklist: blood tests and ECG, echo. These are the must. Like that for the PPH, the moment it is given alert, you ought to take all this blood. We cannot be checking each and everything whether you did this test or not done that other test. So make sure that the blood is collected for all that things. So laboratory person should be alerted. The assistant should know what all the tests to be written and included. Excellent. And how do we approach it? So once we know that there is a PPH, first and foremost is we have to rule out the uterine atony. Immediately you have to do abdominal palpation. If you are seeing the uterus being very relaxed, boggy and soft, you know it's a atony. And again, sometimes the uterus could be felt above the umbilicus because of the blood clots within the thing, or retention of placenta, something we should be checking on that. And send blood as it is for every case. Blood has to be sent, all the thing whatever modes are there, whether it is the emergency procedure or anything, whether we are going to do anything or not, blood has to be collected and sent to the lab. And patient is, if not responding to the hypotension and fluid management, do a abdominal examination, rule out any other cause and uterine inversion or anything. Depending on that, we have to manage. And management, as usual, if you diagnose atonic uterus, then uterotonics are the first line of therapy. Whatever we have, like oxytocin, prostaglandin, ergometrins, and now carbetocin, we are talking, all that has to be started. And uterine balloon tamponade is the one thing where we have to use either balloon, or you can put a Foley's bulb and inflate, or Panicus balloon you can use. You give tamponade for time being, and then start doing all other management. And hemostasis should be maintained immediately. Critical care consultant should be alerted, and he should be on the bedside and to manage the patient. And next thing is stairs and trauma. If you suspect any of these things, immediately explore the pelvis, shift the patient to the OT, and explore the pelvis and the parametrium, and make sure that the bleeding is not coming from the cervix or vaginal angles or hematomas. And this is very important. Again, do a scan to rule out the ultrasound uterine rupture or extension of uterine angles and hematomas within the inside. If you're not able to see, because bleeding is pouring, you won't be able to see small tears and angles, upper uterine angles. You have to do a scan and to see any collection is happening inside also. If it is cesarean, of course, your cesarean, when you're delivering the head, sometimes extension would have gone up to the uterines and sides. So you make sure that you catch hold of those things, immediately open up. Once you see intra-abdominal collection, you have no other go, you have to open up. And extragenital causes, again, some rare causes like subcapsular liver rupture, sometimes HELP syndrome, which we would have missed it because of hypotension, or suddenly patient coming in labor. So make sure that you rule out all those causes when there is a intra-abdominal bleeding. And investigations, of course, we have to do everything. And ultrasound is must. And management with the critical care team. Always you need to have your own assistant. You will be managing the patient side, and they should be managing their cardiovascular system. And then you have to see that pelvic arterial embolization also can be done. So may be required in subsequent cases. I'm going to explain. So those are the things, extreme cases, but any labor patient you have to be prepared. And retention of tissue is the another thing. It's not very dangerous, but if you are diagnosed, then it is good. So retained placenta, once you examine your placenta in a normal delivery, you have to put your hand and make sure that there's nothing, bimanual examination, and again no bits are retained. Many times in IVF cases, being a fertility specialist, we know there is a twins, triplets getting reduced, and sometimes one twin miscarriage, vanishing twins, some one fetus becoming a miscarriage after 11, 12 weeks, sometimes retaining of their chorionic and the fetus on one side, we may not be able to identify. Once this placenta is coming out, we may not be able to recognize. Sometimes we might even forget. when many cases are there, we might forget which patient has got reduced or not, because after that it is mentioned everywhere as a singleton. So these are the situations we have to completely examine the placenta, and sometimes placental abnormalities can be there, anatomical anomalies can be there, and examine under anesthesia, do a manual examination, and remove the retained placentas. Another thing is coagulopathy. If you already know something abnormal with the patient like ITP, or yesterday also one patient from Bombay, they called saying that a patient platelets are very low and she's going for a labor, and one of the patient they called up and then asked like that, patients they will be prepared. If we are not prepared, or she's on already going into coagulopathy, something undiagnosed, so we have to be ready for it and diagnose immediately, involve the vascular surgeons and hematologist. Next slide. So rationale of developing these systems. See, now we know all these things. We should, as an obstetrician, you know, these are all the causes which are all can be managed by ourselves, which are all can be prevented. Trauma, of course, it is uncontrollable. Only if you do a controlled delivery, if you are having all the precautions properly, giving perineal care, using the proper instrumentation, giving proper pressure, perineal support, all that you can prevent. Again, coagulopathies you can diagnose and manage with the team, and you know that retained placenta can be removed. What we don't know and how we cannot control is the uterine atony. So here we have a lot of uterotonic agents. Now, what is that missing? In spite of having all that, still we are lacking. No, we are still not able to give immediate attention and control of the uterine atony in certain conditions. So here we see that this is a development of carbetocin in a new heat stable formulation. What is the reason they brought in here? Carbetocin is available in a room temperature stable formulation. It is also available in convenient vial presentation. What happened is like oxytocin and other ergot alkaloids should be kept in a refrigerator to avoid degradation. Though even in a developed places, people don't keep the oxytocin inside the fridge. Sometimes they bring it to the labor room and keep it there because the patient is going to deliver anytime. So these are the some temperature stability is not maintained, and then again you will face a problem. And that because it has to be kept under 2 to 8 degrees centigrade, no? So that has to be maintained. And oxytocin is not a heat stable formula, so that is why it is not currently available in a heat stable formulation. So we should also know about that, all those storage methods, and whether it is stable in room temperature or not, and all those things should be understood. And again, resource poor countries, they may not have this cold chain maintained. Even they would have kept it outside, and they would have transported. The logistics may not be correct, but when they bring it, you will keep it in the fridge. But by then, the drug would have lost its potency. So that is the reason we say that it is very difficult to maintain in a low developed countries, maintaining the cold chain, and knowing that whether this drug has its own potential or not. So that is why we are trying to get some formulation where we are able to have a longer half-life, which can be stable at room temperature, and also in a humidity countries like us, and avoid a long-term like need of cold chain storage. So these are all the advantages we are looking for it. For that, this carbetocin is developed. And well, a lot of molecules so far we were using like oxytocin or carbetocin, ergometrin, symptometrin in our international centers. Mostly they use symptometrin as a routine protocol, and misoprostol is a wonderful drug now we started using. And all these drugs can be used at say any time at the crowning of the baby's head, at the delivery of anterior shoulder. We generally give at the time of delivery of anterior shoulder, at the end of second stage labor, and also following delivery of the placenta. Only few drugs here we cannot give before the placental delivery. So we have to make sure that ergometrin and carbetocin, we have to be very careful till we deliver the placenta. Again, in prophylactic use, if you take it, some drugs can be used only for prophylaxis. Other drugs can be used for even induction and prophylaxis and prevention. And therapeutic management, again, only few drugs can be used as a therapeutic drugs like oxytocin, ergometrin, all those things can be used. Carbetocin cannot be used for only treatment. It can be used as a preventive drug. And again, it's a next generation drug. This is a drug which is a synthetic long-acting analog of oxytocin, and it is mainly developed to prevent postpartum hemorrhage due to uterine atony, and it is no, supplied in a vial, 100 micrograms of carbetocin in 1 ml solution for injection. And it has got a prolonged half-life and reduces the enzymatic degradation. It is created by making several modifications of the same oxytocin structure. They modified in certain levels and made it a heat stable product. So next, so once any new drug comes, there should be any evidence. Again, the drug has to be compared with many drugs, like commonly available drugs, their efficacy, their side effects, whether they are superior to the available drugs, whether they are not inferior to the other drugs, what are their side effects, and all those things, additional methods, cost effectiveness, like multiple studies have to be referred and studied. That is how this molecule has come out. Here, if you see the difference between the first thing is, I think you're not able to see the heading. The first column is the oxytocin, second one is the carbetocin. And oxytocin is a synthetic cyclical peptide from naturally occurring posterior pituitary hormone is getting secreted. That is where this oxytocin is applied. And this usually this oxytocin binds to the receptors in the uterine myometrium, stimulating the contractions of the uterine smooth muscle action. And carbetocin is a long-acting synthetic analog, again with the agonist properties and the same action. Once it is given, again it also binds with the oxytocin receptors and give the same action. Now the difference here is the mode of route of administration. When you give in the IV oxytocin, it takes the immediate action with a peak concentration after 30 minutes. But in the carbetocin, it gives a sustained uterine contraction within 2 minutes. So it takes within 2 minutes, but lasting for about 6 minutes, sustained contraction, followed by rhythmic contraction for almost 1 hour. That is the extended action is there. When you use it in intramuscular region, that slower onset of action is there. It takes almost 3 to 7 minutes, but produces longer lasting action up to 60 minutes. In carbetocin, when you use sustained muscular contractions are there lasting for about 11 minutes instead of 7 minutes. And again, these contractions are maintained for almost 120 minutes, that is 2 hours. Again, if you compare the off life, this is 1 to 6 minutes only, but this carbetocin has off life of 40 minutes. So we have enough time and enough sustained contractions, and maintenance is there for almost 1 to 2 hours, which is very important for us to get prepared for other modes of therapies. And storage and transport, this is the main thing why this product has come up, because required from the oxytocin is has to be protected from the light, and storage has to be kept at 2 to 8 degrees centigrade. But at the same time, carbetocin can be kept at room temperature. And indications, there are differences. Oxytocin, of course, we can use for induction of labor, augmentation of labor, prevention, for everything. But carbetocin is mainly for the prevention of PPH. Other than that, other things are not studied yet. That's what we can say now. So, when I said that clinical evidence, when we compare with other molecules and again mode of actions and side effects, this is one trial where WHO has done, and it is the largest clinical trial in the prevention of PPH. And here you see that the study design is non-inferiority, double-blind, randomized trial. And to compare the effectiveness of the safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. More than 30,000 women were studied, including India, and they have studied the outcome of proportion of women with blood loss of at least 500 ml or use of additional uterotonic agents. Again, with more than 1000 ml also they have studied. So what is the outcome? They have studied their efficacy of blood loss more than 500 ml or the use of additional uterotonic between the two, blood loss of more than 1000 ml between the two. Again, addition of adverse event. That's very important. At least one unanticipated adverse event and one serious adverse event also they studied. Both the groups, both oxytocin and carbetocin group have the similar percentage in everything. So it shows that This carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or use of additional uterotonic agents. Here, even if it is not superior, it is not inferior, it is equally comparable and equally efficacious. That's what this study means. Again, Cochrane data, and they've taken 11 studies involving 2,600 patients. And for the women who undergo cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonic compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries, and is associated with significantly fewer side effects. That is what the Cochrane review has published. Next comes the guidelines. Many countries have changed their guidelines and they've included carbetocin as a first line of therapy. So here you can see every country it is included, and all the sources, mainly FIGO, WHO, Canadian this guidelines, Germany, France, all the people they've included now carbetocin as a first line of therapy. So when we talk about this drug, so what are the clinical scenarios? And recently, whichever patients I have faced, I have just put up three different categories of reasons. And other than that, other causes we all know that is very, very rare, but we all be prepared for it. Here is a case she is a multi-gravida, but G2P1L1. Previously, also she is conceived with us, but normal conception and had a cervical incompetence, and that is only diagnosed during the fifth month anomaly scan. She came with a 2 to 3 centimeter dilatation, bulging of membranes. We did emergency circulage and put her in the bed and head up, head down and all the things, and with the tocolytics. And she went up to 35 weeks and delivered. Second time she conceived again spontaneously, and this time prophylactically we put a muslin tape and circulage was done. And then again, this pregnancy, she came with the pains and PROM by 36 weeks and expected a precipitate labor. As previously also, she had a precipitate labor. That time we thought because she had a already dilated cervix, when we removed the cervical stitch, immediately she progressed and delivered. But here again, we expected, but not that fast. Immediately she went into labor and delivered, and delivered by our assistant, and the bleeding was happening, and prophylactic carbetocin was given. All the tocolytes were kept ready. Only thing is, because this mescaline tape, I had a doubt. So immediately I was there only nearby only. I came, and because uterus was very well contracted, patient was stable, and but it was bleeding was coming little excessive, and immediately they called me, and then I suspected. I just did a PV. I can see cervix hanging out like both the sides, like bucket handle. So immediately we put under examination in the labor room itself. We just gave analgesic and expo, and we could see cervical tears, and immediately we took a stitch and bleeding was controlled. Here again, what I'm saying is, when we use a prophylactic carbetocin, so that we have enough time, uterus is very well contracted, so there is no confusion, and we know the history, and we should be prepared for all types of PPH. But here, because we know, we are able to immediately take it. We not even shifting the patient to theater or anything. Again, no blood transfusions were given, and the patient was managed. This is one way that even in precipitate, atonicity is very high. That is why this carbetocin really helped, and she didn't have atonicity only because of the this muslin tape. When she came in a labor and PRO, when it was removed, it was thick, no, so some trauma was there. In that, it got extended. That is what we have found it. Next slide. And next case is that it is 2 years back. You like no, she is also primary IVF twins, and she was on anticoagulants till 32 weeks because she had a severe endometriosis, adenomyosis, multiple surgeries and treated, and multiple IVF failures also. And she got pregnant with us through ICSI, and all the time pains and like no bleeding, spotting. So she was always on tocolytics and admissions. We planned for elective delivery. They requested us for a hysterectomy since she has gone through a lot and they don't want to do any more procedures because 36 weeks baby was around 2.3 or 2.4 and everything was okay. They said that they don't want their parents also, they don't want her to suffer anymore, and then if at all possible, if any bleeding, any complication happens, to remove the uterus. That is what the consent has been given. And after the delivery there was a pph. We, as we expected, it was not very well contracting. Even placenta was only that, no, up to the fundus and outside the skin we were able to see that, no, only thin layer of serosa was there. That much of invasion was there, but still we could remove the placenta, and we were able to control. We gave carbetocin and oxytocin, of course, additionally we are given in this patient, and we were ready with all the modes of blood and everything. And but we were able to remove, and controlled contractions were there. Though they were asking us to remove, we thought that we will manage, and we did a baleen suturing, and uterus was very much controlled and okay, and we convinced the parents and family, and she was managed very well. Here again, because of this prophylaxis, that atonicity was controlled, and we had a time to discuss with the people and think about it. Even to have a confidence in doing the conservative management was possible. Next slide. This is the case very recently we had, meaning 1 year, just a few months back. She's 46-year-old and had IVF pregnancy with us. Almost many IVF failures, and one IVF we did 4 years back, and she conceived with us, and had IUD, and that time placenta previa, complete placenta previa, and that we had to do hysterectomy and remove, and we were that time it was too much of bleeding. Since she didn't have any baby, we had to retain her uterus, and we did all the possible things, and we retained the uterus. And again, in between, she had a previous also, she had a myomectomies. Then after that also, we did one more myomectomy for multiple myomas and many surgeries in the uterus. Very thin lady. And again, this time, second IVF, again with us, whatever remaining embryos we transferred. After 2, 3 years, she came back, and this time again, it is a complete placenta previa with the multiple pregnancy twins. And we planned for the delivery after 26 to 28 weeks. Till then, it was very nightmare for us because IUD one risk was there, and very thin built with all the complications, and always bleeding, pain. Like, no, we don't know whether we'll be able to save these babies also. So by 28 weeks, we were able to give max self and prophylactic all the steroids, and we took her for a delivery, elective delivery we planned, because patient was always complaining of pain, and we wanted a intervention radiology support also. This patient was very well explained, and we planned for intrauterine balloon, and we placed the balloon, and we went for a delivery. We delivered the babies, and then here again the patient and attendants, because of the age factor, lot of risk factors and surgery, if at all anything required. Here we ourselves told that she might land up with hysterectomy because saving will be very difficult. If at all required atonicity, will not think, we will remove the uterus. That is what we mentioned and got a consent. Then after that, the delivery, and we didn't try to even remove the placenta beginning, and but uterus was contracted, and slowly we removed the placenta, and bleeding was controlled because of the balloon also was there, but uterus also very well contracted and everything. And again, after some time, then a little bit relaxation was there. So we didn't want to take a chance, and patient is given 100% consent for remove the uterus. If I don't remove, and after doing everything, then tomorrow again re-laparotomy would have been a bigger thing. So we again spoke to the relatives, and they said, no, even 1% chance it is going to come. Please don't wait, and remove it off. So that is how this patient. But we had enough time to do check everything, and then lot of additions were there. We were able to. Then we did a hysterectomy and save that mother. So next slide. So this is how like we did a catheter in the intervention radiology department. Then brought it here. I did only midline incision above the turn of fundal area only. I did a incision, removed babies, both the twins, and then immediately I closed that rent. After that, we were just monitoring for contractions and bleeding till we make a decision. And then after that, finally we have decided that after removing placenta, everything also we thought okay, then again we thought that we'll remove the uterus. We have removed it. So this again another picture I have added after the removing the placenta. So next slide, please. So this is how this patient now at least he put on a little bit of weight. Both the babies were doing fine. Now just 2 weeks, 3 weeks before only they came to see me after the NICU discharge. So both the babies are doing fine. So sometimes this is the extreme cases, but we have to be prepared and we need to know all the aspects of thing. Here when we are talking about carbetocin, it gives us the time and it gives us some confidence. Contraction uterine atony is a little bit like you are able to control that till you make a decision and do that. Definitely comparably, like when you compare with the oxytocin, here you have a sustained contractions and long lasting contraction is there. That is one good thing everywhere. Even the peripheries corporation, I talk to the doctors who work in corporations, they are also very happy now. That is one thing we will be able to save here. These are the extreme cases. We have to go for additional mode of thing. But as a routine patients, we have a lot of high risk patients. Nowadays, we don't require so many things. Like those days, we used to give methogen, like ergometrin, syntosine, so much of bolus of oxytocins used to be given. Lot of intrauterine packing and balloons and other things. Those are all the things. Now it is very less. So it's happy to see that at least one part of that PPH we are able to manage. So we have to be ready for both your use prophylaxis. If it happens, be ready for the therapeutic options. Next slide. Okay. So thank you for your patient listening. And every patient is important. We have to be prepared and we have to save each and every patient. If at all preventable, we can always prevent by using all the prophylactic and preventive measures. And if it is not preventable, not able to manage, of course, you need to have a team spirit and you have to refer the patient on time and make sure the patient goes to the safe hands and gets all the support required. Thank you so much.
Thanks,
So now
madam.
let's
Thanks
panel
for sharing
discussion.
these cases. I mean, the case three was really interesting. Seven IVF failures and then afterwards coming with so many things. Is it possible that, madam, because of multiple fibroid removals, the uterus was not contracting properly? Possible.
Possible adenomyosis. Along with that, they always
Yes.
develop hyperestrogenic status.
Okay.
Only myomectomy, one is that the risk of rupture, that muscle, multiple myomectomies.
Yeah.
So it is
Scar
not done for,
tissues.
yeah, scarring and things are there. Then in between adenomyosis, they will not respond. Oxytocin receptors would have gone and like no response will be bad.
And those two small children, they would never realize what went in their delivery.
Yes,
But it was
yes.
nice to see them smiling there. You know, it's finally the result which matters. And as you rightly said, oxytocin, I mean, carbetocin gives little time for us to decide and discuss
Yes,
with the.
yes,
Yeah.
that is nowadays because another thing everybody knows that like when you want to do ergometry now this one we have to be very careful whether they have a cardiac problem,
Yeah,
whether
yeah,
they have
yeah, yeah.
problems and anaphylaxis. So many things we have to be very careful. Here it can be used like it is a first line drug nowadays.
And you know what? One of the worst thing in our country is that many patients are not coming out with their past history very clearly. I mean,
Yes, they
yeah,
will not tell
for
us.
yes, and for a patient it was not important PPH, but for us it is PPH. For patient it was mild bleeding or something like that, and that's
Mild
what
bleeding.
matters. And second is that anemia to add to that.
Yes, a lot of people have anemia, and even when we say iron injection or tablet, they'll not take. Still, it is happening. Even in
Yes,
cities,
yes.
don't take tablets and don't come for the iron injections.
Absolute,
And
absolute.
8 grams, 9 grams, still they'll be roaming around because they're compensated. They'll not be having any symptoms. They think that they're all right.
Correct, correct,
And
correct,
when
correct.
they go for preterm labor, no, that's the biggest problem. Suddenly preterm on that night, one sometimes blood group negative, sometimes rare blood
Oh,
groups.
bapre.
Very difficult. By the time you have to save all everything, no?
Yeah,
And
yeah, yeah.
8 again in them also it is very high.
And there'll be hemodilution. It is less, even little blood loss is very critical for them.
Very immediately they'll go into circulatory
Yes,
collapse,
yes.
no? These are the situations we'll be able to use this and have a contraction without even checking. Nowadays, government is very strict in doing echoes and other things.
Yeah,
Nowadays,
yeah.
insistence is there, but sometimes we get wrong idea. They'll go to some local area and get the
Oh,
technician. We know that lot of regulations are coming up.
good.
Still, no, that echo and cardiac underlying problems we don't know. Sometimes they say because of this cardiomyopathy, depth, no on table, those things we are still facing. No.
Correct, correct, correct. Let's come into some of these panel questions. What is the benefit of using carbetocin? In fact, you have discussed this. I don't want to take your time.
Yes. Yes.
Where the doctors can anticipate a PPH?
This, as a gynecologist obstetrician, you should predict, anticipate in every patient, of course.
Yes, yes, yes.
But
Very.
when it comes to real indication, if you see multiple pregnancy is the commonest thing we see now, and large babies, anemic patients, or any sepsis.
Hydroamnios possibly. Yeah.
A chronic leaking nowadays in IVF patients, no, even if they have leaking, we have to wait because they don't allow us to terminate. So these are the endometritis patients, like no, when you suspect some kind of low sepsis, placenta previa and
Oh, yeah.
abruption, those cases, and preeclampsia again. Yesterday night also we had a severe preeclampsia up to
Oh,
220 per 120 BP with
Baapre.
all IV, Labetalol, Maxal, so many drugs loaded. Still, it was taking time because patient was not coming for checkup at all. They were
That
doing
is the worst part of
this
this.
and that, you know. So they
That is
will
the worst
say
part.
all those things. So that is how we land up with that. So we have to be prepared for all those indications. And any IVF pregnancy, again I say, because they'll go on lot of tocolytes, progesterones, uterus is so relaxed and soft.
Yes, correct.
We have to be prepared for all the IVF patients. I always make sure that you have to anticipate PPH.
And they are given these tocolytic, I mean, they are
Yes,
given these drugs. Yeah.
yes.
Yes. Any experience of using it in RH negative mothers, madam?
Yeah, we can use carbetocin can be used either positive or negative. We can use. There is no such thing.
Madam, after even after using carbetocin prophylactically, does the patient get PPH, or even if the patient gets PPH, is the intensity of PPH low as compared to?
So that is what that no again we don't know. After few years we might get an idea. Now that
Okay.
statistics like no not many patients are having PPH. Like no every other patient we used to have excess bleeding, excess
Yeah.
loads of oxytocin we used to give.
Yes, yes,
Now
yes.
post operative post delivery we are not giving that much of oxytocin. Requirement is very less. And carbetocin because it is going well, maybe a large volumes after few years we'll come to know
Come
that
to me.
usage of adjacent additional things are less. Actually, say speaking, this prostadine, no, carboprost.
Yeah.
Nowadays we are not using. We used to use no left and right when atonicity is
Correct.
there, even intraoperative. We used to give it to the uterine musculature, and we used to
Direct
immediately
injection. Yeah.
anesthetist will give immediately when we are talking about atony and all. Nowadays it is very less. If you compare that way, it is definitely reducing.
Yes, 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 yes. Possibly because carbetocin help. That's good. And those prostaglandins again, they cannot be given to asthmatics and other
Yes,
issues.
yes, asthmatic
Methargine,
and other people.
hypertensive.
Yes,
Yeah.
yes. There are so many things, indication we have to check every
Yeah,
patient.
yeah,
No?
yeah.
Each drug has a little bit of a contraindication.
Absolute. And worst part is that patient doesn't come out with the history of asthma, for them.
Mhm.
Yeah.
Yes, yes.
Oxytocin is used for labor induction, but the doctor can definitely use carbetocin for prevention of
No,
PPH.
we cannot use
Cannot.
because
The
see
same
sometimes
receptors.
yeah we don't know like in the earlier stage when for induction and all we are not sure about it. Even oxytocin is not generally used as induction. Only augmentation it is safe.
Augmentation. Yeah.
Augmentation is safe. So carbetocin, we don't know the titrating IV low, like no, titration is not studied yet. Maybe
Correct.
in future it may be there, but at present we are not.
No. You generally prefer IV route, madam, over IM?
Yeah, it is IM is preferable because
IM.
immediately when the delivery is happening in the side, they will be just immediately give it off.
That's correct.
And IV if required, we can give. If it is very severe, if you are expecting, you can always give IV.
Or other uterotonics, the carbetocin scores in terms of course, the storage is a major advantage, I
Yeah,
suppose, as
storage is
compared.
the biggest thing because even we have seen our patients oxytocin giving not even nothing is happening. Then you check it, they would have taken from the pharmacy and kept it 2 3 hours back itself.
Yes,
And
yes,
they're like,
yes,
no,
yes.
these sisters to avoid their running around that time, they'll keep it and that. And
Anything is
patients will
possible.
not
Yes.
use AC and they'll keep the room like very hot. under the lights. So those are the things we have found that it is not acting. Anesthetist will be shouting sometimes. Then we go and take the fresh thing and
Yeah,
come, and it will be working. So
correct.
these are all the things not there with the carbetocin.
Yeah, that's a major advantage. And second thing is that, in the interiors where there is no facility for refrigeration, or I mean, power outage happens even in big places, big cities like
Big center.
Chennai,
Yeah,
Mumbai.
yeah.
Yeah,
No,
yeah,
actually speaking, in a big center, multi-specialty, we have faced it because we
yeah.
also go to multi-specialty hospitals where the labor room will be in one floor, theaters will be somewhere other floors. In the
Oh,
labor
yeah.
room, they'll not give fridges, no. So all the stocks will be kept in the OT pharmacy or OT
My
will be in
God.
the second floor, third floor. By the time they'll get a permission, go inside and take and come,
Yeah,
and now we
yeah.
have to go to the IP pharmacy. These are all the things always happens, no.
Every minute matters here.
Yes, yes, golden hours.
Then other uterotones, if you have to use, what will you use in your order of preference? Suppose if carbetocin is
Carbetocin is not, next line is oxytocin only.
oxytocin
Also,
only,
nowadays misoprostol is there. So we generally try to give a misoprostol, either keep
misoprostol.
it in the rectum and line put it inside the uterus also. So that is nowadays easier thing.
Yeah. Should it be kept as a reserve drug?
It should be definitely kept as a first line
First
only.
line, right, right, right.
Why something is doing good, something is better,
Exactly. And
and
life is at stake. Finally, life is at
yeah,
stake. Yeah.
it doesn't matter whether because of new drug, new product, something is better than what we
Absolute,
have
absolute,
so far.
absolute.
Even if it saves 200, 300 ml an hour stress, and that is the best
In
thing
our
we.
country, that's a big volume. Looking at the anemia and looking at other things, hypoproteinemia, I mean, that's a big thing. To conclude your take-home message for the audience.
Overall, it is not like no, we are promoting something or anything
Yeah,
because
yeah, yeah,
this
of
is a
course.
wonderful drug. It is whichever brand it is, like now
Yeah.
it has to be there used as a first line of drug because every patient predict and always prevention is nothing wrong actually. Whether it happens or not happen, that is different. At least as a first line, we should give it off so that it is a life saving drug, so we can use this and then be prepared for if it is not getting controlled because there are some cases where they are not the oxytocin receptors are not responsive, they're not working. Always go for the algorithm and put it inside the labor room or cesarean section. Next, you have to have a PPH drill and go for it and make sure that the patient is safely managed. But as of now, what we have among all the other uterotonics, you can always use this carbetocin at the time of anterior shoulder, unless we expect some additions of placenta previous additions or something, then you always wait for the placenta to come out and then
Okay.
give the carbetocin. This is the only basic principles we can always follow it, and make sure that you stock some amount of carbetocins in the labor room, and then make sure that no, it is given even if you're not concentrating, that a staff nurse or also assistant has to be no, alerted when you're going for a delivery. It should be loaded and given. That is a thing. Definitely we will be able to have a good experience, and in a low resource setting, mainly don't even think to give it off an anterior shoulder coming itself.
Thank you so much, madam. It was
Thank
wonderful hearing your experience and sharing. Thanks for sharing those case studies. I'm sure the
you.
audience has benefited out of your experience. Thank you so much.
I
And
hope
thanks
so.
all the doctors who took time from their schedule and attended this webinar. I'm sure you have
Definitely.
benefited. Thanks Sanjana, thanks IT team, thanks sales and marketing team, thanks Bivas for this coordination. Once again, thank you so much, madam.
Thank
Uh,
you, sir. Thank you, Dr.
thank you.
Prashant and Hetero Healthcare,
Thank
and
you.
all the audience who are. I hope you all are understanding. If anything is there, you can